Specialty pharmaceuticals are an important class of medications used to treat life-threatening conditions like cancer, HIV, inflammatory conditions, and others. As more and more drugs become available in this class, there is concerns about their spending due to new drugs, increased utilization, and expanded indications for their use. With this increased cost has become increased attention and scrutiny by public and private payers. So what they've done is they've put these complex, often expensive molecules into a separate formulary tier. In fact, about a quarter of private payers will have fourth and fifth tiers that often have coinsurance, which is a percentage of payment that patients have to pay, as opposed to co-payments, which is a flat dollar amount, which is frequently what our patients use for drugs to treat hypertension, depression, and heart disease. So as more and more of these drugs are put into this specialty pharmacy tier, they're asked to pay more out of pocket. And if you ask people to pay more for something, they buy less of it. So there is this legitimate concern, backed up by research, of what we call cost-related non-adherence. So we want to think about tools and solutions to make sure that the right drug will get to the right patient at the right time. One of the tactics we could use to ensure access to these potentially life-saving drugs is value-based insurance design, or VBID. VBID is based on the premise of clinical nuance, that medical services differ in the benefit they provide, that drugs to treat one condition may be more valuable than others, that certain types of doctor visits more be valuable than others. The existing type of plan in the United States has something called a one-size-fits-all cost sharing. You pay the same for every drug within the tier of the formulary. You pay the same for every diagnostic test. You pay the same for every doctor visit. We are trying to add this idea of clinical nuance to the specialty pharmacy realm, and understanding that certain drugs in certain situations are extraordinarily high value for money and want to mitigate these concerns regarding cost-related non-adherence. There are basically three ways that I could see VBID be implemented. First is that we identify certain drugs that we see to be so high value that we would remove them from these somewhat contentious fourth and fifth tiers for which patients have to pay a substantial amount of the cost of the agent to get it to them. To add on top of that, I think the second idea is to incorporate a little bit more of this clinical nuance idea, understanding that patients are different and diagnoses are different and where you get care is different. I think cost sharing might be based on patient-specific or disease-specific type of conditions. A good example would be a companion diagnostic test. In cancer, there are a number of these tests that kind of predict the likelihood of the success of a particular specialty pharmacy regimen. What if patients undergo these testing, they're encouraged to do this with minimal or no out-of-pocket spending, and for those patients who test positive for the marker of drug success, the cost sharing for that drug be reduced. I think this is an intuitive idea that should be considered, if not implemented, by most public and private payers. The third way to implement value-based insurance design is not through the specific service, whether it be the drug or the doctor visit, but in fact, where the care is provided. You could use value-based insurance design to steer individuals to those venues of care where we know high-quality, cost-effective care is delivered. So imagine you could use VBID to steer individuals to centers of excellence to where we know not that they produce the lowest cost care, but they produce the highest quality care, and that patients undergo interventions that comply with guidelines of high quality care, whether they be cancer or other conditions, ensuring that cost is one part of the equation, but much more importantly, that quality of care remains paramount in our evaluation of these programs.